Thank you, folks, and welcome. This is the Sight and Sound Bites webinar series brought to you by the Eye and Ear Foundation. This bi-weekly webinar series started in April of 2020, and we've now actually done 18, or this is the 18th broadcast that we've done, and we're very happy to bring these to you. This what you'll hear today highlights the research at the University of Pittsburgh School of Medicine. Today's topic, robotic surgery, present tense and future directions. I'm Lawton Snyder. I'm the CEO of the Eye and Ear Foundation. The Eye and Ear Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck at two of the world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide from the Eye and Ear Foundation to support research are only made possible because of philanthropic support. Actually, you'll hear a lot about work here going on today that Dr. Duvvuri is talking about, and most of what Dr. Duvvuri got started was with philanthropic support. So thank you for everybody who's supported a lot of the work that gets these projects off the ground. Some housekeeping rules. We disabled chat for this. I know people use Zoom used to using chat, but you can use the Q&A function, and that's what we prefer you to use to ask questions. You can type in your questions anytime during the program. We get to all the questions at the end of the program, and I'll read those for you. And then you'll receive a survey tomorrow, and that survey is valuable to us, so please fill that out. You'll also be added to our email list for future webinars, should you so desire. To introduce today's speaker, I'd like to invite our distinguished service professor and chairman, Dr. Jonas Johnson, Department of Otolaryngology, and the Eugene N. Myers Endowed Chair at the University of Pittsburgh School of Medicine, to introduce Dr. Duvvuri in today's program. Dr. Johnson.
Thank you, Lonnie. So welcome to everybody and good afternoon. We're delighted to have you with us today. So if you're interested in changes in medicine, technology has really allowed us to do things that we could never dream of doing even 10 or 15 years ago. And robotics is one of those changes. Duvvuri has been on the front line of the introduction of robotics to our field. He is the director of robotic surgery in our department. And with that, I'll ask Dr. Duvvuri to go ahead and take it away.
Thank you, Dr. Johnson and Bonnie, and thank you to everybody that's here. I hope you can hear me okay. So, in the next half hour, 40 minutes or so, I wanted to take our audience through this journey of surgical robotics. They're talking about the present and where I think the future is going, both in the areas of throat, head and neck cancers, which is sort of the particular emphasis. But at the very end, I'm going to talk a little bit about the work that we're doing and how we're engaging to improve the care for patients with other types of diseases as well, and how robotics can sort of impact this area. So we'll sort of talk, the next few minutes about three parts of the talk. First, sort of define what robotic surgery is, why it's important. Then talk a little bit about robotic surgery of today, which is what I mean by present trends. And then finally, we'll end with where I think robotics is going to go in the future. So this is a little video of sort of robots, right? This is what people think of in general when we talk about robotics in the world currently. So these little guys are little, they're quite big actually. The robots, they're building cars, So we keep sort of talking about automation and how automation is moving the field forward. So here you can see that was a car that was on the assembly line. You can see this little jig down here. So that's one car that was rolled through. Here's another car that comes through, and you'll see this little jig kind of flips up and holds it in place. And these robots now start going to work. And they are building the next version of the car. So this is really sort of an assembly line model of how robots are used in the commercial space. So when we talk about this, a lot of patients sort of think that robotic surgery is similar, that there's some robot that walks into the room or is wheeled into the room and does the surgery of its own accord, so to speak. But the reality is that, at least in the medical space, robotic surgery is not autonomous. It doesn't allow for the surgeon to disengage from the procedure. Really, robotic surgery is, in some sense, microsurgery, very delicate surgery, in which the surgeon performs the procedure by manipulating the hands of the robot. So here is an example of one such robotic platform where the surgeon is sitting at this console and is using this console to manipulate instruments that are at this distant site. So that's really what robotic surgery is in the current way that we use it in the operating room. And so it may better be defined as robotic assisted surgery or computer assisted surgery rather than robotic surgery per se. Now, this type of surgery does have some advantages that we think it leads to shorter hospital stay. We've shown that definitely for patients that suffer from head and neck cancer. I'll talk to you a little bit about that and why that's so important. It reduces trauma to the body because we don't have to make as big of incisions as we typically would to do surgery in the traditional or open way. And because of this, there should be less anesthesia required to do these surgeries, especially if they're being done more quickly. Less blood loss, hopefully less pain, both post-operatively and longer term, and ultimately a faster recovery and return to daily activities, which is what really all of our patients want. Right? They want to get back to their lives in as smooth and quick of a fashion as possible. And that's what we're trying to give people with this idea of robotic surgery. So the most common application in my area for robotic surgery is to deal with people that have cancers of the head and neck region. Now, head and neck cancers are relatively rare in the grand scheme of things. There are only about 50,000 or so new cases a year in the US. So when compared to lung or colon cancers, there definitely are less. The majority of these cancers are derived from what we call the squamous mucosa, or the pink stuff that lines our head and neck region. So the pink tissues that are inside our mouth. The reason that our tongue is pink in color is because it has this moist mucosa that's called squamous epithelium. This tissue is what leads to the tumors, by and large. And often these tumors are caused by exposure to carcinogens such as tobacco and alcohol. But we are having a change more recently. We're seeing a different type of cancer. We'll talk a little bit about that because I think it's particularly important for people to understand why head and neck cancers, although they don't seem to be quite so common, are actually increasing in size. So here we have two distinct types of cancers of the head and neck now. They're still called head and neck squamous cell carcinoma. That's the technical term for this. But here we have a lady who is clearly a smoker, and she is enjoying her cigarette here at the ripe old age. But these carcinogenic properties of tobacco lead to mutations within our cells that ultimately cause cancer. And there are several, genes that are mutated and are altered by smoking, and this leads to cancer. We're not going to go into the details of that at this point, but I'm happy to answer questions in chat afterwards if anybody's particularly interested. But then we also have a relatively new type of cancer that we're seeing, and this is a population of patients who suffer from tumors that are caused by the human papilloma virus, or HPV. And HPV is clearly a virus. It's a papilloma virus. We're hearing a lot about viruses nowadays, especially with the pandemic and the COVID. But this is a different type of virus. It doesn't spread through aerosolization. But the human papilloma virus is oncogenic, or at least certain types of this virus are oncogenic. And so if one is unfortunate enough to be infected by one of the oncogenic variants of HPV, usually type 16 or 18, then this virus can actually get into a cell, can incorporate or exist within a cell, create its viral proteins, and these viral proteins hijack the machinery of the cell and cause the cell to then become malignant. Not every cell, but some. And so HPV can cause this malignant transformation within cells and can cause HPV-associated cancers. And so what we're seeing is that there is now a changing face of head and neck cancer. It's not the typical smoker, drinker who is suffering from this sort of cancer. Many of these patients that have HPV-associated cancers don't smoke, they don't drink, they're younger in age. And in fact, it is gaining, unfortunately, it's becoming more and more common in the populace. For those of you that might follow the NFL and the National Football League, Ron Rivera, who is the coach of the Washington Redskins, was recently diagnosed with HPV-associated head and neck cancer and has completed treatment for it, and now clearly is back on the sidelines coaching his team. And so the impact of HPV-associated cancer is now being felt much more, I would say, commonly in the populace. And this data sort of demonstrates that phenomenon in more sort of stark or black and white terms. So this is a graph taken from a paper written by a colleague of mine, Anil Chaturvedi, who is from the National Cancer Institute. Anil has been studying a lot of this more carefully. And so what Dr. Chaturvedi has shown is that in the past few years, between 1988 to 2004, when this paper was studied, the incidence of oropharyngeal cancer, or cancers of the back of the throat, that is including the tonsils and back of the tongue, have been increasing. Whereas cancers of the same oropharynx that are caused by smoking and drinking, or that are HPV negative, have been relatively decreasing, and the tumors that are HPV positive are continuing to increase, or had increased. And these are now continuing to increase. So HPV positive oropharyngeal cancers increased by about 200% over those past few decades. Whereas the incidence of HPV negative cancers have actually declined by about 50%. And we attribute this to better education about the perils of smoking. And so we think that people are not smoking quite as much in general in this country, although there clearly are certain areas like the tobacco belt where tobacco use continues to be a major problem. But the recent trends seem to suggest that HPV-associated cancers are actually increasing. And in fact, we see the same phenomenon at UPMC. So this is data taken from our own experience of the people that we're seeing. And as you can see, that based on this data from 1980 to 2015, there has been pretty strong increase in the incidence of these HPV positive cancers, these oropharyngeal cancers. It's by about 4 or 5% per year. And this number seems to be continuing on this trend. And in fact, what's particularly shocking in my mind is that human papillomavirus associated oropharyngeal or head and neck cancer has overtaken cervical cancer as the #1 virally associated cancer in people. So I know we've heard a lot about cervical cancer and the vaccinations for cervical cancer to prevent cervical cancer from the papillomavirus in women. Well, it turns out that when you look at the actual overall data, men who are now suffering from oropharyngeal cancer has overtaken the women suffering from HPV positive cervical cancer. So this is really a striking phenomena, which suggests that over the next few years, we're going to be continuing to see this increase despite our attempts to immunize and vaccinate people. This is that same data shown in a slightly different way, that despite current attempts, we see an increase in the prevalence of this disease, as well as the incidence of this disease over time in our patients. And interestingly, these patients are younger at diagnosis. The median age has decreased over time, so younger and younger people are getting head and neck cancer. But also, there's a very important finding here that there's an 18-fold increase in the frequency of 5-year survivors. And what this means is that patients who suffer from HPV-associated oropharyngeal cancers, not only are there more of them, but we're actually able to cure them or treat them better, probably because the HPV-associated cancers are more sensitive to treatment. And what we also find is that surgery for these patients seems to be associated with improved survival, even though these patients have oropharyngeal cancer, which traditionally has not been treated with surgery. And this is where the robotic stuff kind of comes in. What we're finding is that based on these data and others, there is in fact potentially an indication to use surgery to treat these patients with oropharyngeal cancer. Now, in the traditional era, where these data were sort of taken from, these patients were treated with surgery in very open sense, a very aggressive sense. So these patients often had surgeries that would require performing what we call a mandibulotomy, or literally breaking the jawbone to swing the mouth open to be able to get access to doing the surgery. And so that was very invasive. It was very morbid for the patients. And that's why more and more surgeons moved away from doing those surgeries and moved towards treating these patients with chemotherapy and radiation therapy. Well, in the late 2000s, I would say 2007, 8, etc., we had the advent of robotic surgical techniques. And so this is the Da Vinci surgical robot, one of the particular robots that we use to do this kind of surgery. This robot has a telescopic arm that allows us to get magnified vision. It has these wristed instruments that mimic the motion of the surgeon's hands. And so by using this technology, we were now able to operate on these patients, not by making big incisions on their face and neck, but rather by putting this robot directly into the mouth of the patient. We could access tumors in the back of the throat, areas of the back of the tongue, the voice box, the larynx, and what we call the hypopharynx, and also the tonsil, by putting these tumors directly, by putting this robot directly into the mouth and accessing the tumor, and then we were able to resect it. And in fact, this technology was developed here in Pennsylvania. It was the first center to have a large experience with it was actually the University of Pennsylvania, my colleague, Dr. Greg Weinstein. And he published this series of patients, a very small cohort, about 27 patients who were treated with this surgical technique for having tonsil cancer. And he found that they had very, very good outcomes. They were able to get the tumor out in all these patients, and patients did very well. So this really set the trend for many of the surgeons in the country to want to adopt robotic surgery to attempt to improve the quality of life for our patients. And this really comes from a fundamental point, which is that patients who have chemotherapy and radiation therapy often suffer from the side effects of chemotherapy and radiation therapy, including difficulty swallowing and dry mouth. And so the thought was that maybe surgery could be used to obviate some of those side effects. And so I will show you a little bit of that data in the near future. So this is just another picture of how we sort of do this surgery. We open the mouth, we see tumors in the back of the throat, and then we bring this robotic system into the field. You can see that it's displayed on the TV screen here in the room, and surgeons and everybody can sort of see this magnified view, and then we can then perform the surgery using this robotic system. This is just a really brief video to show you what this kind of surgery would look like. So this is, the back of the tongue of a patient. This is where the tonsils are. And so there's a tumor sort of hiding in the back of the tongue here. And we are actually removing this tumor using this surgical robot by making an incision in the back of the tongue and then doing very elegant, careful, and directed surgery to remove tissues in a very controlled fashion with very little bleeding. And this sort of technology has actually revolutionized how we take care of some of our patients with head and neck cancer. And so we're now doing this resection, and we're taking out some tissue in the back of the tongue in an attempt to find this tumor. I'm not going to bore you with the details of this particular case, but it was a patient with what we call an unknown primary carcinoma hiding in the back of the tongue. And then we'll do the same surgery on the opposite side. And so now we can remove a really nice a portion of tissue, which can be submitted to pathology. The pathologist can then find the tumor. We can remove the tumor completely. And these patients heal very well. This is a post-operative image showing the voice box, the vocal cords, the epiglottis, which is the top of the voice box. And here's some scarring of where the tissues were removed, but you can see it's healed very nicely. And these patients often go on to have very good function with swallowing. And remember, I told you there was this really significant improvement in survival rates. So this is some data from my colleague Carol Fakhri, who published this recently, showing that patients who have head and neck cancers are able to have really good outcomes with HPV-associated cancers. Sorry. So now the question is, can we use robotics really to avoid giving patients additional therapy and to prevent them from having the side effects of chemotherapy and radiation? This is a very elegant study that was done by my resident at the time, now colleague Garrett Chobe, who's at the Mayo Clinic. He trained here with us and then went on to take a faculty position at the Mayo Clinic. This was a study that was funded by support from the Eye Foundation. And what we were able to do was look at a cohort of patients who were treated with surgery alone for HPV-positive cancers. And we found that when we looked at their quality of life, that they recovered back to baseline within a few months of their surgery. So yes, after surgery, there is pain, there is difficulty swallowing, there is discomfort that is expected, that is, as one would expect after having any kind of surgery, kind of like having a knee surgery, it hurts. But after you rehabilitate, after you convalesce from the surgery, people go back to having a good quality of life. And that's what this data sort of shows, that after about 6 months of surgery, they come back. We didn't take time points in between, so we don't know exactly how quickly people get back to their baseline, but this is some data that's recently been studied, and I will show you some a recent clinical trial that was done based at the University of Pittsburgh that we look forward to having the data from within the next couple of weeks, actually. Again, when we look at other markers of quality of life, such as swallowing, pain, chewing, and general activity, everybody sort of recovers back to some semblance of baseline at about 6 months after surgery. So this tells us that surgery for the right patients, if we can avoid giving adjuvant therapy, adjuvant meaning post-surgical therapy, these patients have a really good outcome. So the questions that we're currently studying, that we seek to continue to understand, is who are the right people to have surgery? Does upfront surgery improve quality of life? Does it change survival? And we don't know that yet. We're studying these patients. We're trying to figure this out. Does it improve swallowing? It seems to do so in selected patients, but this is still being investigated. Who are those select patients? We hate doing surgery and then finding out that the patients had some bad prognostic factor which required them to get adjuvant, that is post-surgical treatment with chemo or radiation. We don't want to do that. But sometimes it happens, and we're trying to figure out who the right people are to do this surgery for, so we can do what we can call now personalizing the care for the patients, giving the right patient the right treatment at the right time. We're making steps towards that sort of pathway, but we're not there yet 100%. And finally, what's the expense, or what is the value associated with robotic surgery? Can we find ways to make this treatment less expensive? Because clearly, if we operate on people but don't have to give them additional treatments, it should be less expensive. So, that would be great if we could give people value-based care so that patients have the best, outcomes. So on that note, in terms of cost effectiveness of robotic surgery, this is another study that came out of, this is published actually when John D'Almeida was at Mount Sinai, but he was actually one of our former trainees. He's now at the University of Toronto, and John has a master's in public health and has a strong interest in value-based care. And so John did this analysis of cost effectiveness of robotic surgery versus chemoradiation for these HPV-associated oropharyngeal cancers. And what he found is, by doing the sensitivity analysis, what we call it, if you can avoid giving therapy, any adjuvant therapy, to 70% of patients, then you will have made surgery cost effective. It is more effective and more value-based than chemoradiation if you can do this, but we're not here yet. Because we don't know a priori which patient is going to benefit from surgery and not need chemo radiation in the adjuvant sense. And so these are some of the patients we're trying to identify who is the right patient to get this therapy. But we now know what we should be shooting for. So in an effort to get to this stage, we just recently completed a large clinical trial that was run at multiple hospitals, multiple institutions, with about 75 surgeons. This is called ECOG 3311. This stands for the Eastern Oncology Group, Eastern Cooperative Oncology Group. This was led by my partner and colleague, Dr. Bob Ferris, who is now the Cancer Center Director. And if you remember a few slides ago, I told you that when these first cases were being published, there were about 25, 27, 30 cases. Well, this study accrued over 500 patients. So over 500 patients were accrued to this study. The majority of them fell between these two arms. So patients that had, risk factors that we consider intermediate risk factors were randomized to having reduced radiation versus standard radiation. And we evaluated these patients. People that had very low risk disease had surgery and then just observation, no treatment at all whatsoever. What was really interesting, and finally, there was a high risk group, people who we thought would benefit from surgery, but turned out to have a lot of lymph nodes that had cancer in their neck, turned out to have positive margins. That means that we didn't get all the cancer out with the surgery. These patients went on to have high risk or intensified therapy afterwards. Well, it turns out the survival for everybody in this group is about 90%. But the best survival happened in these patients with observation who didn't need any additional therapy. And then these two arms were equivalent at about 92%. And finally, we had the radiation therapy, the people that had high risk disease fall in the high 80s. And so we now know that some of these parameters are important for stratifying outcomes in these patients, but we still don't know how to judge which of these patients have high risk features before we get into the operating room. Preoperatively, can we tell who has bad outcomes? And that's really where the next frontier is going to lie. So as I talk now about some of the current trends and transition to the future, what I wanted to show you briefly was some of the novel techniques that we're doing for the surgery. Remember, I told you that robotic surgery we typically perform by putting the robot into the mouth of a patient to remove a tumor in the mouth, in the back of the tongue. However, we don't have a good way to remove the lymph nodes where these tumors can often spread to without making an incision on the neck. And this often leads to the morbidity for the patients. So I'm the first person in North America to offer our patients minimally invasive approaches to remove these lymph nodes. And so we can actually perform robotic assisted lymph node dissection or lymph node surgery by making making initially a skin incision, lifting up the skin, identifying the lymph node packets, bringing in the surgical robot, placing it within this remote access here, and then performing surgery to remove the lymph nodes. And when we do this, we can actually see not only that the patients have a very good cosmetic outcome, which is really important, but I'm going to skip this in the interest of time. I'm sorry, maybe I could go back and sort of move this along a little bit here. But I wanted to show everybody that it's not just about the cosmetic outcome for these patients, but rather that these patients have a very good functional outcome. We know that many of these patients, when they have robotic assisted surgery, tend to have what we call lymphedema, complications of swelling of the skin, etc. And we don't often have that with these patients. But I know I'm running short on time, so I can talk about this for a very long time. But I wanted to talk a little bit briefly in the last maybe 4 or 5 minutes about the surgeries of the trends of the future, of where we're going and what we're going to be doing for these patients. So one of the key areas that we struggle with is controlling the blood vessels in the anatomy of these patients as they go through surgery transorally. And so the depth of the tumor is often very close to major blood vessels, and we cannot really control these vessels very easily, which limits the number of patients that can have these kind of minimally invasive surgeries, because bleeding is often the result of what we call surgical misadventures, and we don't want to have that. So one of the techniques that was developed here at the University of Pittsburgh, and this was again funded by the generous support of the Ioneer Foundation, is to use intraoperative ultrasounds to be able to look at the blood vessels and look at the depth of the tumor, see how deep the tumor is, and see where these blood vessels are. These are blood vessels that they're shown with this Doppler flow. And so we can see these blood vessels. We can now use this ultrasound probe. We can look at the surgical image as well as the ultrasound image within the surgical robot. And then we can know exactly how to dissect this tumor and in fact control these blood vessels before we encounter them and before we get bleeding. And so this is a lady that unfortunately has recurrent head and neck cancer. This is not HPV associated. This is actually an HPV negative or smoking and drinking associated cancer. In fact, I believe this was a patient of Dr. Eugene Myers who had surgery many years ago, and then unfortunately developed a second cancer. We were then able to now see where this vessel is close to the depth of the dissection of the tumor. So we know that the vessel is coming up upon us, and we're now able to ligate this blood vessel before it causes any trouble. And we can sort of see some of the delicate pulsations of the blood vessel. And you can see here that these blood vessels are hidden within these layers of fat. So if one didn't have a way to image this, you might very easily miss that. And you would just sort of do surgery and maybe make a cut with the cautery, and then you'd have bleeding that you'd have to deal with. And so this allows us to sort of see that, but this is still a bit of a bulky and cumbersome method of doing this sort of surgery. Nonetheless, we can delineate this tumor margin, we can remove the tumor specimen completely, and this patient went on to have very, very good outcomes. And we've done this in a handful of patients, and we've published on this, and so this is very, very interesting technology. But the surgery of tomorrow is going to obviate the need for us to bring in an ultrasound and put it into the patient's mouth, or use multiple types of technologies and fuse them, if you will, manually. It's going to become more and more automated. You know, the surgery of tomorrow is going to have robotic technologies that are multi-articulated, sort of snake-like arms, because straight stick instruments, which I've shown you, are great for hollow tubes. But clearly, the human body is not a hollow tube, right? We have curves, we have different parts of anatomy that we need to get access to. So this sort of multi-articulating arms are going to be really important. We may be able to see this preoperative imaging to determine what patient would benefit from what type of surgery before we get into the operating room. And so these are some of the techniques that I think are moving forward. These are some of the robotic technologies, and this is a slide that I borrowed from a colleague of mine to talk about how the future is going to go. And here, this is this concept of actually repetitive surgery. So you could actually have a true robot that could sew automatically, where the surgeon defines you go from point A to point B robot, and the robot will actually perform that repetitive motion, much like the car engine. Not that it's going to do the whole surgery, but certain parts of the surgery might be automated under the close observation of the surgeon. And this is some of the new technologies that we're coming forward to. So here you can see these are some of the robotic platforms that are currently on the market. This is the first generation, if you will, the Da Vinci SI system. It developed into this now XI system, which is what we use for many of our robotic surgeries. And now here's the latest and greatest technology called the single port, which is more like an articulated snake-like device, if you will, that allows people to do surgery in very, very sophisticated ways. And this is some of the technology that we're trying to develop and accrue in the near future at the University of Pittsburgh. And here is an example of doing some of the surgeries in a cadaver model that we did in the past. So as we see these technologies developing, what we're going to be getting to in the very near future, I think not too distant future, is not just using the surgical robot as a tool, but rather as a critical component where we integrate all these concepts of patient care, intraoperative navigation, molecular imaging to be able to see where the tumors are and how deep they are and whether they've spread or not, and maybe eventually, remote surgery. So currently we are working on a platform, again, through the gracious support of the Eyenear Foundation, where we've built these monitoring carts, telemonitoring carts, where we can actually proctor surgeons in Hammett by staying in Pittsburgh. So we can help surgeons in Hammett do their surgeries a little bit better, or give them more comfort by having the expert surgeons at Pittsburgh collaborate with those surgeons up there. And we've done this for gynecology, and we're actually in the process of publishing this. So we're not yet of doing remote control surgery, but we are able to proctor and help our surgeons in our system at different sites with the expertise that we have at the sort of mothership, if you will, at Presbyterian. And so I don't want this to sound like an advertisement for Intuitive Surgical, the company that makes the Da Vinci robot, but that is the only robot that we have currently available for use, in a broad sense. But there are many robots that are coming forward, and we are working with each of these companies to help to develop their versions of robotic technology. So this is a system called Versius from CMR Robotics that came out of Cambridge. And this is another very interesting robotic platform that's not connected to a central boom, if you will, but each of these arms is independent, but is controlled again by a surgeon sitting at a console. And finally, there's this other robotic platform called the Star Robot, or what we call the active robot. I'm going to turn the sound off here because I don't want to put it together, but this is a company called Active Surgical. And we're working with this company through the auspices of a think tank that we have here called CREATES, Pittsburgh CREATES, which is a collaborative for research, education, and technology enhancement in surgery. So CREATES allows companies to work with surgeons and scientists at the University of Pittsburgh to develop the next generation of robotic platforms. So we're working with this particular Star robot company called Active Surgical that's based out of Boston to develop this robot. And as you can see, that idea here is that this robot can actually do semi-autonomous surgery. It can actually perform sutures by itself, if you will. And so this is what this sort of robot looks like. This was published in the journal Science Translational Medicine a couple of years ago. This robot was the brainchild of a robotic surgeon, Peter Kim, who was in DC and now serves, I believe, as a chief medical officer for the company. And so the University of Pittsburgh and CREATES is working with this company to help to develop this technology. So here's actually a robot that can actually do suturing. These are the dots that are laid out by the surgeon, and the robot actually literally performs the suture. It puts the suturing in console. So one day we may actually have this sort of concept of semi-autonomous robots, but very interestingly, the company is not stopping there. They're actually developing ways to look at the blood flow within patients without having to give the patients any sort of drug. So this is called laser speckled imaging or hyperspectral imaging. And you'll see here that this is sort of this image of blood flow, but this is an animal model in a lab of an animal where you've got kidneys and you've got kidneys here, and you've got the arteries and veins, and you can hopefully see that within this sort of anatomy, if you turn on this laser, it shows you where the blood vessels are and what kind of flow exists in these blood vessels. So if you go back to that video that I showed about using the ultrasound to see blood vessels buried within layers of fat that are not obviously visible to the surgeon, one may be able to just flip a switch and see these blood vessels and then do more precise and delicate surgery and avoid complications that may come from the surgery. So these are all the sort of concepts that are on the horizon. And I think it's really, really interesting. And I think that robotics right now is at it's sort of at its inflection point, is just about, I think, to take off. While the existing technology is outstanding and we are doing really interesting work with it, I liken it to the quote unquote old computers of the past. Those of you that remember the very first desktop computers that came out, they were quite big, they were expensive, they were clunky. And now I would submit that this little phone that we carry around, has 1,000 times the computing power of those big clunky computers of the past. And so clearly there's room for improvement, and robotics continues to develop and improve in this way. And the ultimate goal, however, is to not lose sight of our mission here, which is to provide the highest quality of care for our patients. And so what we're doing at the University of Pittsburgh is not just adopting these technologies as they come out because it's interesting or cool, but rather studying these technologies in a prospective sense to ensure that these technologies are being applied carefully, and that we are good stewards of our resources so that we give our patients access to the most cutting edge technologies, but also in the most meaningful way possible. and not subjecting our patients to unnecessary or needless surgeries or adventures when we don't know that these things are actually going to help them. So it's a delicate balance, but this is what the foundation has been so helpful in providing us with seed funds to ask some of these questions, do some of these studies, so that we can translate these data to our patients in the most effective way possible. So with that, I'll stop here, and I'm happy to answer any questions, and I look forward to your comments. Thank you so much.
Dr. Duvvuri, thank you so much. This is always a very intriguing topic, and you shared a lot with our audience today. We're getting a few questions. I'll start with one because I think this is, I heard you mention the telesurgery opportunities that may be available in the future. What are the limitations to that? What are the barriers to allow for you to do a surgery on somebody in another state or another county, with the technologies that exist today, or even the telecommunications as it exists today?
So I would say the vast majority of the challenges, the vast sort of the big group of things that affect this is actually veracity of bandwidth, right? I mean, you can imagine that if you're sort of watching something live streaming, it's really annoying to watch Netflix and have it be jerky. So, think of that, but with someone's surgery, right? You don't want that to be jerky. So we really need to make sure that the bandwidth issues are resolved and that we are able to do the surgery in a very smooth and seamless way. And in fact, we're working towards that. I'm actually on a phone call later this week to try to address this exact question. Can we put this bandwidth together? Because it's my personal belief that just because someone happens to live in a big city doesn't mean that he or she should have access to better care than someone who lives in a smaller city or a more rural area. So this is what I like to call the democratization of surgery. We really are trying to make sure that everybody has access to the best quality of care, despite their geography, if you will. So I think that this is very doable. This is definitely one of the main items that we're working on. But of course, these sort of projects require a lot of time and effort, right? We have to work through the logistics. We have to start not just by jumping in and doing surgery on a patient, but by doing maybe just a small laboratory where we can just show that you can move little pegs on a board in Altoona from Pittsburgh, and then demonstrate that you could do something in an inanimate object, maybe do an animal lab or a cadaver lab. And there are lots of steps before we get to actually trying to do this for a real patient. So stay tuned. I think this is coming to an operating theater near you, but it's not quite ready for prime time yet.
Well, we have questions that have already come in, and I'll remind our listeners here that if you go down to the bottom of your screen, there's a Q&A bubble that you can click on, and you can type in a question, and we're going ahead and I'll start taking some of those for Dr. Duvvuri. So the first one is, I'm curious to know if robotic surgery is and or can be potentially utilized for nerve transplantation for nerve deafness conditions in the ear.
Yeah, this is I saw that question on chat, and I think it's a very, very interesting question. I'm not aware of anybody who's doing that particular investigation presently, but it is. But there are people here and in other places. We're working with some colleagues at Carnegie Mellon, for example, who are working to develop a robot that can do semi-automated cochlear implantation for nerve deafness. But if that operation, the cochlear implant, requires the nerve from the cochlea to the brain to be working. So if that nerve isn't working, then yes, you would need to have something called a brainstem implant. I'm starting to get out of my depth here as a neuro-otologist. I should defer this to my colleagues or specialists. but those kind of operations are far more sophisticated, but there's no real reason why robotics can help in those operations. But again, what the role of robotic surgery is and how exactly it's done in those kind of cases remains unclear. It is true that there is a robot that has been developed for doing this cochlear implantation, and that is, I think, moving through the process of the FDA in the near future, and that has shown some promise.
Very interesting. So, has there been any retrospective quality of life studies on patients that might have been eligible for tours had it been available?
I'm not sure I understand exactly the question. Retrospective.
Quality of life. I guess just to look back to
what
see,
it would have
yeah.
looked like. Yeah.
Right, right.
Well, yeah. So I guess the question then is, had this surgery been available 20 years ago, what would it have done for that patient?
Right.
I understand the spirit of the question. I cannot say that I can answer that, because what we're finding, unfortunately, is that despite the actual technique of the surgery, what we're having a problem with finding out is who is going to benefit and who responds in what way to having the same operation. Just like no two people respond the same exact way to the same dose of blood pressure medication or diabetic medication, we're finding that no two people respond exactly the same way to surgery. Some people have very little pain. Others tend to have excruciating pain and are relegated, if you will, to having a change in their quality of life, although we did, the same operation for both of those people. So it's I understand the spirit of the question, but I don't have an easy answer for that right now. But what we can say is that it does seem that robotic surgery improves the quality of life for the patients who do have it. So therefore, if a patient were eligible for this and they had robotic surgery, based on the ECOG 3311 data, which was presented at one of our large meetings, ASCO, and the paper is currently being written right now, the quality of life data seem to support that robotic surgery is in fact good.
Thank you. Okay, well, is Pittsburgh a place that is on the cutting edge of robotic technology because of CMU, Uber, and other companies here?
Yeah, the short answer is yes. We are on the cutting edge. And the longer answer is, I think we could be more on the cutting edge. We are doing a lot of very interesting things. I think I showed you guys a little bit of the technologies that we're sort of working on and what we're doing. Having said that, I think that there's great opportunities for, even better development, better technologies, better and closer collaboration with artificial intelligence companies like Uber and GTA. Uber self-driving car division apparently is merging with another company, which I just heard about. And so there is just a tremendous amount of intellectual firepower that we have access to with CMU, with Uber, with many of these companies. But what's really important here is that we have a tremendous amount of intellectual firepower in the medical side of things, right? Translating these concepts that are used to self-driving cars or industrial robots, like building cars or building airplanes. There's lots of industrial robotics. Translating those concepts to the care of our patients is not so trivial. And that requires really close merger between surgeons and engineers. And that is what we have done, and we continue to try to do, because if we can push that to the next level, then I really think Pittsburgh would be a place where, which sets the bar.
Very well, I agree. I know that you've done a lot and worked really hard at trying to put Pittsburgh on the map for all those reasons, and I applaud you for all your efforts in championing that, and you have done a lot to do that, as I'll boast.
And of course, I would be remiss if I didn't acknowledge and thank our donors, if I didn't thank the really generous support of the Ioneer Foundation, because with those seed funds, we've been able to now really drive this entire field forward and move beyond just ENT or throat surgeries into gynecology. I told you about remote proctoring. We look forward to doing more and more of these in lots of different specialties. And then that's really the power of this, is growing beyond our sphere of influence and expanding this work throughout.
This is an interesting question. This is from a former mentor of yours, but what about the new salivary gland found by accident behind the nose?
That's a really interesting question. I've been reading about this. So I think more work needs to be done. So it does seem like it's a salivary gland. Is also only visible on a very particular type of PET tracer. It's not visible on regular PET imaging, which is why nobody else saw it before, because most of these things of anatomy have been identified over the past 2,000 years that we've been studying the human body. But there's a very specific PET tracer that was used to identify the structure, which seemed to be sort of tubular structures next to the nasopharynx, which is really behind the nose. So it's unclear what the significance of this is. And at the same time, it's also, well, they haven't really identified the histologic core of this. In other words, they haven't taken those patients to the operating room and looked, or done this on, let's say, cadaveric studies to identify these tubular structures and to see whether that's really truly a salivary gland, which is what we presume it is, or is it sort of some sort of an artifact? And can we find this in a better way? So stay tuned. Again, very interesting stuff. We keep learning things about the human body when we thought we knew everything over the past thousands of years that we've been studying it. But I think it's very interesting, and probably though it's going to just be academic curiosity. I don't think that this really has a major functional role, although I may be proven wrong.
Okay. So, you mentioned Pittsburgh creates and some of the innovation that, that you're able, or the surgeons here are able to do in collaboration with companies and so forth, is an overall goal as we're looking at robotic surgery down the road. Are all the companies or all of the device manufacturers looking at trying to make everything more minimally invasive, as well as less trauma, or are other things like navigation and imaging and other things driving the field right now? What are the things that people will expect in the next few years that'll really make some changes in surgery so that surgery is less invasive?
Yes, I think it's sort of both. Definitely, there were. I think I showed you this Star robot, and there's a company called Active Surgical, and we're collaborating with them. They're really moving to create smart imaging, smart visualization, using artificial intelligence, using machine learning, etc., to be able to detect tumors better, or even characterize tumors better, so that we know which tumor is going to metastasize or not going to metastasize, or delineate functional outcomes. That's one thing that some companies are doing. Other companies are moving towards developing what we call no-fly zones, so that on a surgical image, you can delineate and say, there's a really important structure over here. So doc, stay away from that. Don't. If you try to go there with the robot, it'll actually push back on you, kind of like lane assist when you're driving. If you're shifting lanes, your steering wheel gives you a little, hey, be careful, right? Wakes you up a little bit so that you don't drift. These same concepts hold true in surgery as they do in other areas. And eventually, we will move towards, I think, telesurgery. I think we will move towards this idea of operating in a remote fashion. A colleague of mine, Mehran Anvari, who's in Toronto, is working with NASA to develop a telesurgery platform to take care of the astronauts that are going up to the moon, or now to Mars. And when they're up in space for a year, what if somebody gets an appendicitis? What if somebody gets, gallbladder attack, right? Needs a gallbladder removal, something simple. How do we take care of them up in space? Right. So Mehran is working on this, and he's actually developed and worked out pathways and packaging technologies to be able to do this surgery relatively seamlessly. Now, the one to Mars is very difficult because the lag is really hard, and it's very, very challenging to see him operate. In fact, when I ran the Society of Robotic Surgery meeting, he showed a video of this, of him suturing in a simulated trip to Mars. And wow. It was so difficult, so difficult. So there's a lot more work to be done. So telesurgery will come. We are working on it, both in places like Toronto and now at the University of Pittsburgh. We are continuing to push on this front, but it's not, again, ready for prime time. So some companies are working in that area. So I think there are lots of companies that are working in lots of different areas. And I think we will sort of see a confluence of all of these technologies coming together in the next 10 or 20 years to truly revolutionize how we take care of patients and truly revolutionize how we do these surgeries. I hope that answers the question.
Yeah, thank you. And I think for people today who maybe don't understand robotic surgery as well, I think you defined it really well. It's really more of a tool that surgeons can use to really enhance surgery. It's not replacing the surgeon just yet.
No.
And
I hope it doesn't ever. We'd like to be able to help people. Although maybe one day we'll move to the days of Star Trek, where we'll all have just a tricorder and you can just scan somebody and fix their broken bone. Right? Yeah. It would be great.
Well, it's already advanced quite a bit. It's really exciting to see. So thank you. We hope to have updates on this topic in the future, but I think that's all of our questions. If I'm not seeing any new ones, I don't. So thank you, all of our participants. I know that we had a nice group today, and I recognize some people's names, and then there's some new folks as well. So thank you. This will be our last Sight and Sound broadcast for 2020, and we'll pick up again after the first of the year. But we've enjoyed bringing these to you, and it was very enjoyable to have Dr. Duvvuri with us today. And thank you again, and look forward to more to come. Have a great week.
Thanks, all.